Okay, good afternoon everyone. So today we'll be talking about adenoid and tonsils. So before starting the slides, I'd like to add upon here. Tonsil is actually the lymphoid tissue of your oropharynx, whereas adenoid is the lymphoid tissue of your nasopharynx. So anywhere we need to understand that adenoid hypertrophy is very, very important when it comes to pediatric population, and tonsillitis or strep throat is very common in our setups. You know why tonsillitis is common? Because of recurrent upper respiratory tract infections. And if in case tonsillitis get if you get unnoticed tonsillitis may later land into rheumatic fever. It might later land into glomerulonephritis. There might be a lot of problems. Right? So I will be discussing about tonsil and adenoid. So first of all, let's discuss about tonsil. So if you see in that particular diagram, you can see crypta magna. So the largest crypts is basically termed as crypta magna. Crypts are basically, ingrowths. It's present like this. Now, this tonsil is a paired structure. It's a paired structure present in your oropharynx, lined by stratified squamous epithelium. Please pick up, okay? Please pick up. Now, the next thing that we need to remember is tonsil. You need to understand that tonsil has a tonsillar bed. The tonsillar bed consists of peritonsillar vein. It has glossopharyngeal nerve. That is why any patient having acute tonsillitis can present with earache. Okay, so a case presentation may come to your ENT department that a 5-year-old boy comes to the ENT department with drooling of saliva and earache. So drooling of saliva is not just acute epiglottitis. Okay, you might have thinking that drooling of saliva, acute epiglottitis, but not just acute epiglottitis. You also need to see the age presentation. Okay, so next is here there will be odynophagia. So it will be difficulty in swallowing food. Why? Because tonsil is present in your oropharynx, right? So if you take in something, it will be very difficult to actually swallow the food. I will clear till here. Okay, next. So I already told you that it is non-keratinoid, it's stratified squamous epithelium, and there are basically crypts. These crypts are actually inward growths, okay? And the largest crypt is known as crypta magna. And why is this crypt important? Now, there is always an applied anatomy, okay? So, whenever you talk about tonsillitis is divided into superficial, follicular, parenchymatous, and membranous, okay? Superficial, follicular, parenchymatous, and membranous. Superficial tonsillitis means the tonsil is just red and congested. But whenever you talk about parenchymatous or follicular tonsillitis, there is actually the pus they get built up in these crypts, okay? And parenchymatous means a parenchyma. So whenever pus gets built up over here, this is actually your follicular. From here it goes to the parenchyma. This is parenchymatous tonsillitis. From parenchymatous it goes to the tonsillar bed, forming an abscess. So it might lead to a peritonsillar abscess or retrotonsillar abscess. So these are the different abscesses which we'll be talking about in upcoming sessions. Okay. Now let's see here. So it's always associated with the oral cavity. So anywhere you have infections of the tongue, infection of the pharynx, it might always follow with the tonsillitis. Okay. So pharyngitis may have, for any person who is suffering from pharyngitis may have a tonsillitis, and okay, this is important. Okay, this is very important. So whenever we see the tonsillar bed, you can see this is a peritonsillar vein. This is a peritonsillar vein. Remember the two fascias, which is actually covering this superior constrictor muscle. So you can remember with the understanding that B is for bahira. Bahira in Nepali means outside. And bahira means, what do you have bahira? You have buccopharyngeal fascia. Okay? So what do you have bahira? You'll have the number 11. So number 11, you'll have your buccopharyngeal fascia. Exactly opposite, tilting. See, first of all, you have B and P, buccopharyngeal. Now opposite is P and P. So that is pharyngobasilar fascia. Pharyngobasilar fascia is actually the pre-component. That is, this 10 number is actually a pharyngobasilar fascia. Okay. And one more thing I would like to add upon. There is palatopharyngeus and palatoglossus. So palatoglossus is forward and palatopharyngeus is backward. So palatopharyngeus, P for palatopharyngeus. So pharyngeus starts with P. So it makes the posterior bed of tonsil. So tonsil lies in two beds. palatoglossus and palatopharyngeus. In between palatoglossus and palatopharyngeus, you have your tonsil. The tonsil's bed is actually formed by peritonsillar vein. It is formed by the forward one is known as, backward one was known as B for bile, B for buccopharyngeal. And already what will happen? Buccopharyngeal is BP, now make it PB, that is pharyngobasilar. Okay? And you have this, number 5 is the glossopharyngeal nerve. Now why is this glossopharyngeal nerve important? Because any tonsillitis can actually come and land up with ear pain. Okay, glossopharyngeal nerve. You know the nerve supply of your ear and EAC. Now next is, what is this? This is your submandibular salivary gland. So any patient who is having tonsillitis might also present with sometimes as submandibular salivary gland infections. Okay, and this is your lateral and medial pterygoid, and this is the mandible. Number 8 is your mandible. Okay, angle of the mandible. Now blood supply of the tonsil can be remembered with the mnemonics T, D, A, A, D, T, tag. Okay, T is tonsil artery, D is descending palatine artery. See, if you have descending, you should also have ascending. So descending palatine artery, ascending palatine artery. Okay, and again you have A, that is ascending pharyngeal artery, and D is not descending pharyngeal artery. Okay, this is D is dorsal lingual artery. So you can see here ascending palatine artery. So some of the you need to remember: ascending palatine artery, tonsillar artery, dorsal lingual artery, dorsal lingual branch of the lingual artery. Okay, so this is dorsal lingual artery, and then you have the ascending pharyngeal artery, descending palatine artery. I told you palatine, it has ascending and descending. Okay, but pharyngeal, it has no descending and ascending, it just has ascending. So remember the mnemonics T, D, A, A, D. Okay, T there. All are the branches of external carotid artery. External carotid artery. Next. So let's talk about the veins. So you know that I already told you about the peritonsillar veins. So paratonsillar veins are there, where there is interjugular vein and pharyngeal venous plexus. Jugular diaphragmatic lymph nodes is also important, okay? Because sometimes tonsillitis, severe tonsillitis may just come with this palpable lymph nodes also. Okay? Nerve supply, glossopharyngeal nerve. And what is the clinical significance? Glossopharyngeal nerve, earache. Okay? Are you clear till here? So, of course, tonsillar function, it is a component of our oropharyngeal lymphoid tissues. It is responsible for local immunity. Okay? So surveillance mechanism. So if in case sometimes you inhale an infection and your tonsil has enlarged, then that is good. That is not bad. Okay? Because your body is protecting. It's protecting. If in case you don't have tonsils, and if it goes to the glossopharyngeal nerve, then you might land up into some problems. So tonsil enlargement, it's okay. Now let's talk about the difference between adenoid and tonsils. So I told you initially while starting the slide only, I told you that adenoid peak growth at 6 years. It tends to decline at 12 years and it disappears at 20 years of age. I told you this one, right? And tonsils, it tend to grow till life. Acute tonsillitis presentation can actually present at 25 years, 30 years. Any person can present with acute tonsillitis, okay? But acute adenoiditis, the presentation is up to 12 years, maximum 12 years. It will actually present with 6 years. And capsular component is hemi-encapsulated structure. The previous diagram of tonsil over here, you can see this one number. This one number over here. This is actually the capsule. This is a hemi-encapsulated structure. Okay? Now, I already told you about the types of tonsillitis in the initial stages. So, please repeat with me. Okay, my cameraman is using that. Please repeat with me. Please repeat. Superficial, follicular, parenchymatous, membranous. Once again, superficial, follicular, parenchymatous, membranous. So superficial means it's just superficially located. Okay, there is redness of tonsil, enlargement of tonsil. Whenever we come about superficial, second one is follicular. Follicular, what will happen? The pus will actually be presented in the crypts. The follicles are present in the crypts. The pus is present in the crypts. In the parenchymatous, what will happen? Parenchymatous, the pus will actually come and stay at the parenchyma. So this is actually the parenchyma. So the pus will actually stay here. This is the parenchyma. And membranous means there's actually a composition of dead tissues outside the tonsil, and that is actually known as membranous tonsillitis. Whenever you talk about sometimes you just see your tonsil in the mirror and it's enlarged and all that whitish component is there, and then that is actually, there's no superficial. You just see a tonsil, it is enlarged, it is enlarged, it is red, it is not enlarged, and that is actually superficial tonsillitis. Second, if it's, it is component like whitish components are there in your tonsils, and that is actually your parenchymatous tonsillitis. Okay? Follicular tonsillitis. Parenchymatous tonsillitis, various pus, sometimes yellowish component may ooze out, and if a thick membrane is present outside tonsil, that is acute membranous tonsillitis. So you can see here, the tonsil is red. The tonsil is red. It's generalized red. It's a catarrhal stage. That means you will have fever. You will have fever. Painful swallowing may be there. You will have fever, painful swallowing. Some uneasiness will be there. Okay. In this stage C, I told you this. You can see sometimes like yellowish, whitish plaque, like features in your tonsil, and this is actually your follicular stage. It's filled with pus visible as yellow-white dots. Okay, yellow-white dots. I told you white components in your tonsil. The third one is membranous. So before membranous, there will be parenchymatous. Okay, parenchymatous. It's not written here. It's not. First is not membranous. Okay, first is parenchymatous, then it's membranous. So membranous, you will see a membrane lining over the tonsil, and this is actually it's not a true membrane, it's a pseudo membrane. That means when you scrape it, there won't be bleeding. When you scrape this, there won't be bleeding. On contrary, if it's a true membrane, okay, there will be bleeding. Example, in the case of colirectal diphtheria, there will be bleeding. We'll come to this, okay? Now come. So Irving-Moore sign. Fibrotic tonsil. So in the case of chronic tonsillitis, you have follicular, parenchymatous, fibrotic. Same thing. Follicular, it's not superficial because it's chronic, isn't it? So follicular, parenchymatous, fibrotic. And if you press the tonsil, the oozing of this pus, and that is known as Irving-Moore sign. What is that known as? Please tell it loudly so that people can hear it. Irving-Moore sign. Okay? Irving-Moore sign. So we have already discussed about the signs also. Congested tonsil, tonsillar pillars are congested, tonsil are squeezed, and then there will be posterior, that is Irving-Moore sign, and lymph nodes may be enlarged. Tender lymph nodes may be seen. Okay? That's why I told you lymph nodes, jugulo-digastric. I told you there also. Now there is one grading of tonsil. This is known as Friedman's grading. What is this known as? Friedman's grading. You can remember this by the name as someone has fried a man in a pan. So Friedman's grading system. Friedman grading says that the tonsil is within the tonsillar fossa. I told you there is two fossas. What is that two fossas? Palatopharyngeus and palatopharyngeus. Palatopharyngeus is posteriorly, right? So if it is within the tonsillar fossa, it's grade 1, Friedman. Now tonsil comes out of the tonsillar fossa, it's grade 2. Okay? There is tonsillar hypertrophy, it's grade 3, but not touching the midline. Okay? And grade 4 is a kissing tonsil. I hope you have a diagram over here. So before this, see here, this is a kissing tonsil. How can you see that? This is a grade 4 Friedman's classification. Grade 4 Friedman's classification. I just use this from Friedman because we have to learn it. Okay? Remembering. So tonsil is in the tonsillar fossa, tonsil is outside the tonsillar fossa, and outside the tonsillar fossa, but it's not meeting, okay, and it's meeting, kissing tonsils. Same thing over here. Tonsil within the tonsillar fossa, outside the tonsillar fossa, tonsil hypertrophy, but not touching the midline, but it now touches the midline, which is known as kissing tonsil. See, grade 1 enlargement. This is known as what type of? Superficial tonsillitis. Grade 2 is enlargement and there is severe redness and there is some this one. So that this is known as grade 2 tonsils. So basically it's outside the tonsil fossa. Here it's within the tonsillar fossa, grade 1. Okay. Usually grade 1 is actually your superficial tonsillitis with reddish tonsillar pillars. Grade 2. Grade 3, see, it's not touching the midline. It has not touched the midline yet. Still you can see this part, right? It has not touched the midline yet, but it is hypertrophied. It is hypertrophied. Friedman's grading system. And see, you can see kissing tonsil, grade 4. Now, there is also this Brodsky classification. You don't need to remember this. PG level, Brodsky's grading. So the thing that you need to remember is, it is Friedman's classification. Okay? Friedman's classification. Now, complications. So, please don't mug up things, okay? Try to understand. So, tonsil is enlarged, so it's over here. So, surrounding tissue may be involved. That means pharyngitis may be there, laryngitis may be there, right? And if it's not treated, there can be earache, associated earache may be there, okay? So, local complications like recurrent tonsillitis. There is a Palisade criteria for recurrent tonsillitis, okay? There might be recurrent tonsillitis. There may be peritonsillar abscess, parapharyngeal abscess, retropharyngeal abscess. There can be pharyngitis. There can be, if in case it's a very much, if in case associated pharyngitis is there along with tonsillitis, later it might lead to laryngitis. Okay, so all this upper respiratory tract can actually, predispose. So first is tonsillitis, intertonsillar abscess, peritonsillar abscess, quinsy, parapharyngeal abscess, retropharyngeal abscess. These are actually the complications of acute tonsillitis. So systemic complications. So why systemic complications will be there? Because I already told you, it's because of beta hemolytic streptococci. Beta hemolytic streptococci, they have cross-reactive antigen with what? With heart endocardium, with the glomerulus. Okay, so that is why it will result in subacute bacterial endocarditis. It can actually result in glomerulonephritis. It can actually result in glomerulonephritis, subacute bacterial endocarditis, septicemia, rheumatic fever, okay, urticaria, and local focal complications. I told you otitis media, ear pain, glossopharyngeal nerve, okay, and along with that, if tonsils are so big enough, along with the adenoid hypertrophy, it will of course affect the hamper. It will hamper the ventilation of your eustachian tube. That is why you often see patients with otitis media. If in case the patient will just present with otitis media and you're not sure that whether it's an otitis media effusion or it's a acute otitis media, you can just look into the tympanic membrane. AOM looks like there will be rings coming out. That is known as a cartwheel appearance. Okay. So second, it can be a cervical abscess. I told you tubular gigantic lymph nodes may be involved, because of which that can lead to an abscess, cervical abscess will be there. So let's revise. Okay. So complications, it will be local complications, peritonsillar abscess, parapharyngeal abscess, retropharyngeal abscess. It can lead to surrounding infections, laryngitis, pharyngitis. Okay, it can lead to quinsy. Now, systemic complications is because of the cross-reactive antigen. It can be glomerulonephritis. It can be acute rheumatic fever. It can be subacute bacterial endocarditis. It can be urticaria, allergies, rashes, septicemia. And now again, focal complication, otitis media. It can be acute, it can be otitis media with effusion, or which is also known as non-suppurative otitis media. There can be a cervical abscess. Okay. Now, what is the treatment of tonsillitis? One and only treatment is antibiotics. You don't need to go for immediately a person comes for tonsillitis, acute tonsillitis case. Do not go for surgery, because this is a contraindication. If you do surgery in infective conditions, that will lead to seeding of that bacteria into the blood, that will lead to septicemia. That is why our management of tonsillitis is medical management. Okay, give bed rest, give adequate fluid. Don't ask the patient to take this cold stuffs like your dahi, or it might be cold drinks. Okay, just give him bed rest. Okay, plenty of fluids. hot foods, okay, and give him nasal decongestants. If in case he is having a nasal blockage, give him antihistaminics. Okay, if the fever is associated with recurrent sneezing, okay, there's discomforts. Okay, you can give analgesics. Okay, you can give aseptic gargle. Okay, so what are the treatment antibiotics you will give is penicillin. Penicillin. If patient is allergic to penicillin, you can give erythromycin. Okay, and right? Okay, this is very important. Okay, so membranous tonsil. Membranous tonsil, there should be a lot of differentials. One will be infectious mononucleosis, aphthous ulcer. It might be a oral candidiasis. It can be a Corynebacterium diphtheriae. Okay, Corynebacterium diphtheriae. Very, very important. It can be a Linson's angina. Okay. Aphthous ulcer, as I already told you. So you should actually remember 4-5 differentials to understand. Okay. Now I told you this is important. The difference between a membranous and diphtheriae. So the main, whenever you talk about this one, yes, I told you this is most important. So this membrane is actually a pseudomembrane. That is why it will be easily removed. Okay, but here it's a it bleeds on removal. Bleeds on removal. There will be bull neck over here in the Corynebacterium diphtheriae. So let's go on. Just let's read it. Membranous tonsillitis more than 5 years. Diphtheria is 2 to 5 years. Why diphtheria 2 to 5 years? Because of the lack of vaccination. So if in case vaccination is not given to children, then in 2 to 5 years they can develop diphtheria. Okay. So onset is acute. Onset is insidious over here. Okay. There is more symptoms, less symptoms over here. Oligophilia is more, it's less. Temperature high, low, tachycardia, enlarged tonsils. Just look into the slides. It's because of beta hemorrhagic streptococci, it's because of Corynebacterium diphtheriae. Okay, there is bull neck, here is jugular digastric only, okay, lymph nodes involved. Bilateral, and that can be unilateral. So this is okay. Now we'll just skip this components because we are more concerned on tonsillitis. Now let's come to adenoid. So, adenoid. I hope you understood about acute tonsillitis, chronic tonsillitis, associated conditions, right? Now let's come to adenoid. Now, adenoid is important. Why is adenoid important? Because any patient residing in chronic adenoid, adenoid hypertrophy along with tonsillitis, and that patient may actually be associated to having sleep apnea. Okay, sleep apnea is very, very, very common if you have adenoid hypertrophy as well as tonsillitis. That usually occurs in children. Okay, what is the apnea? Apnea means cessation of breathing for more than or equal to 10 seconds. Okay, for 10 seconds. Now, if in case there is a patient who is present with adenoid hypertrophy, how will the patient present with? The patient will present with adenoid facies. Now, what is adenoid facies? So, adenoid facies means there is open mouth because the child is not able to breathe through nose, so child will be opening his mouth. There will be alar septum. The alar cartilage will actually collapse because when you breathe in, this will inflate, isn't it? The alar will inflate. Okay, so if you don't breathe in, alar will collapse. Similar to that, if you don't use it, you will be atrophied, right? The third thing, continuous mouth breathing will lead to dental malocclusion. Okay. Continuous mouth breathing will actually, the cleft is actually like this, but if you continuously mouth breathe, there will be high arching of cleft. Why high arching? Because it wants to take more and more, oxygen from your mouth. Okay, so there will be high arching of cleft. When there will be high arching of cleft, understand about your nasal septum. The nasal septum underneath there is cleft, there is a hard palate. So when there will be high arching, there will be deviated nasal septum. So patient will have sinusitis. Again, the same component. It's all related. Okay, nasopharynx. Now, I told you this thing already that the tonsils, it will actually, the adenoid, it actually reaches a maximum size of 6 years and it will totally disappear by the age of 20 years. Isn't it? Are you clear till here? Yes, I think we are clear. Now, blood supply, lymphatics, nerve supply. So, not that much important for adenoid. For tonsil, it's very important. Adenoid phases, this is important. See this picture. So, if in case adequate ventilation is not there to your middle ear, it can actually land up into otitis media effusion. And one of the most common cause for OME is adenoid hypertrophy. Okay, I hope we are clear. What is the treatment for OME? I am going to give Gronate. Don't tell me Gronate. Okay, adenoid hypertrophy, you will just get first of all, no, not incision in the initial case. Okay, so OME, if someone is presenting with OME, then you have to actually give him antihistaminics, give him nasal steroids, give him nasal decongestants, okay, not antibiotics. It's not infective, okay, but and you will watch here 3 months. If in 3 months, if the adenoid size has decreased a little bit, because intranasal steroid it can actually decrease the size of adenoid, okay, and if it has decreased, and if the patient is now breathing through nose, you don't need to do anything, and when we will have subsided. But if in case there's still adenoid hypertrophy, when it's still there after 3 months, then you have to prepare for your OT. And in OT, what you do is you will give a radial incision with tympan membrane in the antero-inferior quadrant of the tympan membrane, and you insert a gromate. Okay. Along with that, you will do an adenoidectomy with the adenoid curate. Okay. So you can see here, I already told you about OME. Okay, OME, and dental malocclusion will be there. There will be nasal blockage. Nasal blockage, why bilateral? Because we know that adenoid is in your nasopharynx. Nasopharynx is backwards, like beyond the poina. So what will happen? Bilateral nasal obstruction. And OME will also be bilateral. It is not unilateral. Unilateral OME in case of adult males, usually Chinese, what will you think of? You will think of nasopharyngeal cancer. Okay, but not right there. Bilateral OME in children, 5 years, most commonly adenoid hypertrophy. Now, see, why did I tell you snoring? Snoring, very, very important. I told you, adenoid hypertrophy along with tonsillitis, patient will present with sleep apnea, and you know, deprivation of sleep at the end of the day, it will lead to snoring. Fat person also, you know, often snores. Why? Because the laxity of this tongue also, you know, it decreases whenever you go to deep sleep. That is why the tongue falls backwards. And adenoid is there obstructing the nasopharynx, tonsil is there obstructing the oropharynx, and this tongue is also suppressing your oropharynx. Of course, there is sleep apnea, isn't it? Now, difficulty in feeling, rhinicular closa, bilateral nasal block, nasal discharge. Now, why pulmonary hypertension? This is very important. Pulmonary hypertension can actually later lead to cor pulmonale. Now, why this? Because, see, you're not taking in adequate oxygen. Adequate oxygen is not there. Because of which what happens is, there's more stress to your pulmonary veins, pulmonary circulation, and that will actually, there will be, you know, sudden spasm of this one leading to hypertension, pulmonary hypertension, and that will later lead into cor pulmonale, right ventricular failure. Okay. And of course, there will be pinch in nose. I told you, because of this LR cartilage, disuse atrophy. I told you this term also in the initial stages. Okay, and see, open mouth, high arch palate. Why did I say high arch palate? The mouth is open. You need more space, more air to go inside. That's where the palate will increase in size. Because of it, it will be impacted DNS, and that impacted component of DNS will again lead to sinusitis. Okay, and pharyngitis, sinusitis, all this component. Okay, in attentive child, this is very important. Okay, in attentive child. So, 5 years old child, mother brings to the department of ENT, complains of, has to be repeatedly called upon. Vishnu. Now, all of time she's calling a lot of times. So what might this be? Come on, you know it. It's OME. Okay, it's OME. So other features like this might be pectus exavitus, nocturnal this may be there. Now you can see in the posterior rhinoscopic examination, what you can see, posterior rhinoscopic examination, you can see an enlarged adenoid. So how will you manage this adenoid hypertrophy? What will you do? Immediately you go for surgery? No, you won't go for surgery initially, okay? So first of all, I told you, mild symptoms, you just be anti-static and deconsistent. I told you, first of all, we'll try with medical management. We'll try with intranasal steroids, okay? If that doesn't work, then we have to go for adenoidectomy. And if it is compound like sleep apnea is there, okay, and if there is problem with breathing, we have to go for surgery, surgery. Now, you can see, you can go for nasal pharyngoscopy, you can just go for X-ray soft tissue view. This is very important, okay? X-ray soft tissue view of the nasal pharynx. Now, this was about a short description. I will just give you a quick summary, okay, quick summary. Tonsil and adenoid. Tonsil, lymphotissue of the oropharynx. Adenoid, lymphotissue of the nasopharynx. Tonsil, if it gets enlarged, medical management. Adenoid also medical management. We are much more concerned about sleep apnea in child, okay, because of the laxity of the tongue muscle, it goes backwards, right? Tonsil, what are the 4 stages? Please say tonsil, 4 stages. One is
membranous.
Okay, one is
Membranous.
membranous. Come on, I told you. Membranous is the last stage.
Okay.
First one is superficial.
So
Then comes
follicular.
follicular. Then comes superficial,
Follicular.
follicular, parenchymatous, and membranous. And what's the classification of tonsil? Come on, I told you, a man is being fried. Friedman's classification. Stage 4 is a kissing ulcer. Grade 1, grade 2, grade 3 is, grade 1 means it is just in the tonsillar fossa. Outside the tonsillar fossa, grade 2. Okay, this is disturbing one. Outside the tonsillar fossa is grade 2. And it is actually outside the tonsillar fossa, but it's not meeting the midline, it's grade 3. Meets in the midline, it's grade 4. Recurrent tonsillitis, there's a criteria, Palisade criteria. Okay. Just look into that criteria. And what are the indications for surgery? If in case it's a tonsillar surgery, I want to go for tonsil surgery. So what is the indication? So if in case I have to go for a trans-oral approach to resect this styloid process, I have to go for tonsillectomy. I have to go for tonsillectomy if it's recurrent tonsillitis. Okay. If there is a condition for your sleep apnea and you have to resect this uveopalatal component, then you have to go for tonsillectomy. So these are different indications. We will talk about this in the upcoming sessions. For now, I hope you got a generalized idea about adenoid and tonsil. Thank you. Please like, share, subscribe. Thank you.